Nurse Choma. I'm an NCLEX prep coach. I'm the founder of Choosing Nursing over at choosingnursing.net, where we help you to pass your NCLEX exam. I'm an NCLEX strategist. I'm a registered nurse. I graduated from San Diego State University with my Bachelor's of Science in Nursing degree in May 2010. So this month is actually my 8-year anniversary from graduating from nursing school. So I'm really excited about that. So, but anyways, though, what I do, like I said, I help people to pass their exam. And I practiced medical surgical nursing for about 4 years. And then about 1 year, I practiced insurance nursing. And then now helping people to pass their exam for about 3 years this upcoming June. And I've been able to turn many, repeat test takers to being licensed registered nurses, to being also practical nurses. I've had success stories with people who took in the exam 5 times and passed, 6 times, 10 times and passed 11 times. So if you're in a position where you need help to pass your exam, you should definitely follow the page right now, because I promise you, we give you great information on here. So go and follow me right now if you're not following right now. And then you can also follow me over on Instagram over at choosing_nursing. And you can follow me over on YouTube at Choosing Nursing. And then finally, you can also follow me on Pinterest at Choosing Nursing. So welcome to everybody on here. So this week we're going to talk about 4 labor complications that you got to know for the NCLEX exam. So the first one is going to be placenta previa. So pretty much what happens is that the placenta is covering the cervical opening. So there's actually 3 types of placenta previa depending on the degree of the covering. Did you know that? So one of the things that one thing that's important for the test, to prevent you from being blind spotted, you should be able to understand as well different types of something. So like even for example with like eclampsia, there's different types of eclampsia. So placenta previa, there's actually also different types of placenta previa depending on the level of covering, like how severe it is. So the first one is you have complete. So complete placenta previa, meaning that the placenta is covering the opening completely. Another type is marginal. So there's a marginal edge of the placenta is about 2.5 centimeters or closer to the margin of the internal cervix. Then you have low lying. This is where the placenta is implanted in the lower uterine segment, but it doesn't reach the cervix. So you have, like I said, complete, marginal, and low lying. All right. So obviously the worst one is going to be the first one, right? So here's the way that we diagnose this. We're going to diagnose this through an ultrasound, right? That's the number one way that we can tell. And this is why it's so important during the antepartum stage that, we assess them, we ask questions about their history, because even though they have this complication, the earlier we can identify the problem, the better they'll still do, right? So that's why the antepartum stage is so significant as a nurse and for the patient. Now here's one thing about placenta previa though. Typically, most mothers, they don't feel any pain, but though they'll experience a lot of bright red blood, right? Bright red vaginal blood, like spotting. So they don't feel any pain, but they'll see the blood. So that may be an indication that they have a placenta previa. So it's going to occur anywhere from about 24 weeks of from the time of 24 weeks of gestation to delivery. All right. So what we normally do, depending on where they're at, it's a conservative treatment, meaning that we're just going to tell them, you know what, go on bed rest, right? So because we can't really do a whole lot because we don't want to give birth to the baby prematurely, right? So we're going to tell them to go on bed rest. They need to stop working if they're working a job, right? That's the biggest thing, is that they need to be on bed rest. I've seen it before. I remember before I had coworkers who were nurses and were pregnant, and then they had to, go on bed rest early because they were spotting. So normally we're going to just tell them to go on bed rest. And this is usually going to be if it's about 37 weeks before gestation. Now, if it's after 37 weeks, ideally, right? Ideally, if it's beyond 37 weeks, then we're going to go ahead and do a C-section. All right, we're going to do a C-section because now the baby is, pretty much close to term anyways. So here's what this is what you'll see. This is a progress. So maybe let's say, for example, the mother is 28 weeks pregnant. All right, this would be the ideal response. The mother is 28 weeks pregnant and she begins to notice that she is spotting or bleeding and she's not feeling any pain. So she would go in to see the doctor, right? And the doctor will do an ultrasound, right? So when you're hearing the information, think about the process of the information. That will help you to retain what I'm telling you, right? So anyways, though, so she's going to go to the doctor. They're going to do an ultrasound. The ultrasound will say, you know what? From looking at the ultrasound, you have a placenta previa. So I would recommend that you don't work anymore. Don't move around. Relax. Right? And so from that point on, ideally, she should be fine as long as she follows the instructions. And then hopefully by the time it's 37 weeks, she can go ahead and give birth to the baby. Right? And usually, like I said, it's going to be a C-section. A lot of these complications, take note of this information. A lot of the complications, normally, they're resolved through C-section. All right? If the bleeding is severely prior to the 37 weeks, then unfortunately they need to go into labor and we need to do a C-section. Second one is abruptial placenta. So abruptial placenta is pretty much the premature separation of the placenta from the uterine wall. So there's 4 types. The first one is external. So the bleeding it's more externally noticed and you're seeing a lot of bleeding coming right out of the vagina. Then it's also separating. Number 2 is concealed or internal. So like I said, external, then concealed. So concealed or internal. So with this one, you're seeing the hemorrhage is occurring within the uterine cavity. Then the third one is partial separation. So with the partial separation, once again, they're having external bleeding with also, it can also be external bleeding and also bleeding that we can't see as well. So there's partial separation of the placenta previa of the placenta. Then the last one is complete. All right, so complete. So this is all abruptial. So external, concealed, partial, complete. So complete obviously means it's totally teared, right? The placenta is completely torn completely. Which is really, really bad. So pretty much this is considered a what? An emergency. This is literally a life and death situation where you need to respond immediately and we need to do something immediately. So with the complete, we're going to see they're going to have a lot of bleeding. They can go into shock. All right. They can go into shock with this one. So complete is the most severe and hopefully the least likely to occur, because we should have identified it prior, and early on. So here's the risk factors that you got to be aware of. So you got to know why would somebody have an abruptial placenta over somebody else, right? So maternal hypertension, they have a history of it before. Cocaine use, smoking, that's another history as well. If they have a history, if they're a smoker, if they have a lot of babies, right? So they have multiple gestations. So women who have, 2 babies, 3 babies, 4, and so forth, they're going to have a higher risk than other women, right? So all those are risk factors. Now, what are the symptoms, right? So the symptoms you'll see is bleeding, pain, abdominal pain, and then they can have hypovolemic shock because of all the bleeding, right? So here's what you want to take note of. So how we respond to somebody that has, either these complications during the antepartum stage is a little bit different than the interpartum stage, right? So antepartum is that period of time where they're pregnant all the way until the time that they have contractions. Versus interpartum is when they begin to actually go into labor, right? So you got to be aware of, what we look out for is different from antepartum stage and interpartum stage. So in that antepartum stage, one of the things that you have to be conscious about doing as the nurse is that we got to monitor how many pads, like perineal pads that they're wearing, is being soaked from blood. That tells us the degree of the separation, right, of the complication. So, for example, if they're saying, it's like I go through, and I'm not talking about, obviously I'm not talking about menstrual cycle. I'm talking about, like, because the bleeding is occurring so much from this complication, it's soaking through these pads. So you have to be aware of, okay, you know what, at 24 weeks, they were soaking like half a pad or something. And now at 30 weeks, it's like 2 pads a day or something. That's a sign that it's gotten worse, right? So one thing that's important, antepartum wise, whether it's abrupted placenta or placenta previa, is how many pads are they going through because of the bleeding. So approximately 1 gram is equivalent to 1 ml. All right. You will have to take note of that for the NCLEX, because the exam, it can ask you, you have a patient who has abrupted placenta. What would be a concern, right? Which of these would be a concern, that the nurse would respond to, or something to that effect, right? And then you see something that talks about the pads, or like they're going through 3 pads a day or something, or that would be a concern. So you got to be aware of antepartum wise. We're monitoring, we're observing how many perineal pads they're going through. Now, during the interpartum stage, that's different, right? So let's say, for example, they have abruptial placenta. They're in the hospital, right? We're taking care of them, everything. Now we're getting ready, right? So I'm going to give you eight steps. Start the IV so we can get them ready for fluids. Check their blood type was number 2. Give them the fluids. Monitor their intake and output. Reduce the further chances of bleeding. We're not going to do vaginal or rectal examinations because they're bleeding, right? And the bleeding is coming from the cervix, so we're not going to do that. And then we're going to go in and put them on bed rest and get ready to deliver the baby. Okay, so that's pretty much what the process looks like. So that was the second complication. All right, the third one, number 3, is preterm labor. So this is unfortunately going to be something that's common. All right. Here's the thing about preterm. Remember, it's called preterm labor, not preterm baby, right? The baby is the outcome of the labor, but this is what the process is. So preterm labor, this is when the mother's gonna experience contractions between 20 weeks to 37 weeks. You got to know the risk factors, right? What are the risk factors for a preterm labor or preterm baby? So you're going to see maternal infection. So the mother has an infection. Like I said, a lot of these problems, the focus is the mother. All right, the focus as far as like what's going on with the mother, and so forth. There's different problems that are specific to the baby. So just bear that in mind. So like I said, multiple gestations, the mother has an infection, third trimester bleeding, between 20 and 37 weeks. Yeah, 20 to 37 weeks. Premature rupture of the membrane, which is called PROM. And then also if the mother has other comorbidities, so meaning that she has diabetes, she has hypertension, all those are going to be risk factors for a preterm labor. As far as medications, right? So medications that you want to know. So I have for you the classification. So you got to be at least aware of the classification. Not the specific names, but like the classification. So you want to know at least the classification, because the test will reference it in that manner as well. So you have tocolytics. So these are the medications that we refer to for this type of complication. So we're going to give beta-adrenergic agonists, prostaglandin synthetase inhibitors, and then also calcium channel blockers. These are all things that we're going to give the mother to try and prevent the premature labor from happening. That's what this is. These are all medications that we're going to give to try and prevent this from being a premature pregnancy. So then the other type of medications you have, and this is going to be given to the baby, is called antenatal glucocorticoids. So this is what you call betamethasone and then also dexamethasone. All right, betamethasone and then also dexamethasone. So with this one, the reason we're going to give this to the baby, so this is to the baby now. So let's say they give birth and the baby is 28 weeks. So we're going to give this to the baby, and we're going to give it to try and reduce respiratory distress syndrome, all right, in the baby. Those are the first three, all right, the first three. Now the fourth one. So prolapse cord, this is when the umbilical cord is dropping, right, into the presenting part. All right. So this is considered a medical emergency, meaning that you have to stop what you're doing and do something right now. This is not a continue to monitor answer. Okay? It's not a continue to monitor answer. It's not a let's just watch and see, let's do something now and then check back 10 minutes later. No, it's an emergency. So when this happens, what puts them at risk is a baby that's breached, meaning that their head is not in the right place. It's not towards the vagina. It's up here, right? So a breached baby, a transverse baby, usually this can occur after premature rupture of the membrane. So that also is another problem that coincides with PROM. One thing that we're gonna do, we want the mother to be in the knee chest lying positioning, Sims positioning. Also as well, the hallmark symptom that we're gonna see for with prolapse cord is a sudden drop in the heart rate. All right, a sudden drop in the heart rate of the fetus, of the baby. That's the hallmark sign with variable decelerations. But the sudden keyword is sudden. So you got to take notice for the test. You got to be conscious of those words. Sudden. So a sudden drop in the heart rate. That's just the hallmark sign. So the first step is that we want to check the heart rate of the baby. Second step, if we can, we want to take a gloved finger and go into the vagina and literally try and relieve the pressure of the fetus's head on the umbilical cord. And usually when that happens, you'll see immediately the heart rate should start to go up. And then after that, then we want to give them oxygen, and then start the IV if we have not already. Okay? We're doing it in that order because think about it. You always want to first reduce, you want to first attack what the problem is before you give the oxygen, because the oxygen is not going to work as effectively if you don't first attack the problem. It's kind of like me trying to let's say I have a bruise in my hand, and it's like me trying to treat the bruise, but you're still hitting me. Right? But you're still hitting my arm. So I need to first stop what's causing the problem or alleviate it first, so that way, the treatment will have more of an effect. That's why you do the O2 second. Does that make sense? Just like also with turning on the, as well as turning, as far as in a different situation. All right, so it just pretty much means that the heart rate of the baby is going down frequently with contractions. That's pretty much what it means as far as decelerations. Okay, so those are all four of the complications, labor complications that I wanted to go over with you today. So number one, the first one was Placenta Previa. We talked about the 3 types. Second one was Abruptial Placenta. We talked about the 4 types of that. Third one was preterm labor. All right. Fourth one was prolapse cord. All right. So we talked about what the risk factors are. So, you know, the symptoms that makes them different, also medications, you know, all that type of important information, and then also treatment. All right. So that's pretty much it.